Basically, I'm from Missouri. I like to see it happening. And the bottom line is this is our landing page. And this just came out with the button at the bottom which says My Cost Estimator highlighted in yellow. Although we launched this in July, our web folks were not ready. They had an emergency project. And so My Cost Estimator ended up being on the landing page, but it was buried in a listing of all kind of activity and functions that our patients could access under financial assistance program. And we knew we wanted it on the landing page because there's three things that patients always ask about. How do I pay my bill? How do I get financial assistance, which could be assistance with getting insurance or the HCE program, and what is it going to cost me? So you'll see later, I'll explain why it's so important on the landing page to have that estimator right there forefront when a patient opens up your website. And then on page 19, again, I know you're going to hear me say this a lot, the disclaimer is essential. And we did have a disclaimer prior. We used something very similar for the web estimator. We did have our legal department review the disclaimer. We did not want to discourage people from using the estimate because, as you know, when you're getting pre-cert from insurance, they always have a disclaimer, well, we're giving you an authorization number, but we're not guaranteeing payment. And we didn't want patients to have that kind of an attitude, but we did want them to understand, and you can see it in the middle, final determination is really critical. So we wanted our patients to understand, we're giving you this information, but you should not stop here. So this is extremely critical, and we did, and it's extremely critical with the verbiage, which our patient focus group agreed with it also. And then on slide 20, we get into the nitty-gritty, and this is really where I'm going to basically say PMMC flourished, and Greg and Terry are on the Steve is on the phone and Terry's on the phone, and Greg, who's not on the phone, also was very helpful, and the entire team of people in managing this project with us. Based on our community and based on the literacy of people as it relates to understanding insurance, et cetera, we felt, and I'm a school teacher also, or was a school teacher, people learn differently. People learn by reading, people learn audio through conversation, and people learn through visual. And it was very important to us to have visuals. It was also very important to be able to filter so that the patients wouldn't have to filter through things that would not even be applicable to them. Again, we didn't want to discourage the patient. So basically, this was put in, and initially we said, well, let's just put in a figure. And then, of course, I said, well, let's do a figure of a male and a female. So the PMMC team was very, very patient, very collaborative, and they brainstormed with us. So the fact that we put a male and female, and visually you could select a part of the body, automatically that started to filter the information in the service category so that we would not have female services when you sort on the male or male services when you sort on the female. So that was the one automatic filtering that we were able to get very, very quickly. Now, for the example, we provided colonoscopy, but you can see below all the services categories that we were actually listing. The word service was used because the word specialty was very confusing to people. And also, there could be services that primary care provides, like vaccines. And so in the world of healthcare, that's not considered a, quote, specialty. It's considered primary care. So that's kind of the thought process we were going through in reference to even the visual and just the service category. On page 21, we had some additional discussions about which services to provide. And again, we took our claims and we ran them by CPT code and DRG from top to bottom of utilization by each payer, actually, and because that can also differ, of course. And then we have some payers that bring in more volume than others. So it was very specific not only to the category of CPT codes of DRG, but also to the category of our payers. And so this basically gives you the services that we looked at. And I can tell you, if you go down a little bit, we're asking for copay and coinsurance, which is, again, took many, many meetings of conversation. The first one where you see my professional services, in Ohio we have many labor groups, teachers, for instance, who have what we call split coverage. Their professional coverage is different than their technical coverage. Now, for our hospital, my department actually is responsible for both professional billing and hospital billing. So for us, our estimator has to represent both sides of the fence. For others, that may not be true. So our first thing was to be able to provide guidance so that if they did have split coverage, they'd be able to put in here what their copays were and coinsurance for both professional and technical. The second question that says that they either know their deductible and out-of-pocket, that's important because some patients may know their deductible right that minute. We're only going to know their deductible based on whether or not we look at it, but another claim could come in, and 2 minutes later that could change. So we give the patient the option to give us as much information as possible. We actually did have on here a selector for max benefits. However, when we looked at our patient population with our payers, max benefits was not something that was really common, and we thought it may cause more questions than not, even if we had a hovered help over it where those question marks represent what we're asking for the patient. So we took max benefits right off of it. Again, we didn't want people to say, I don't know that, and leave our website. So the next one on page 22 is being able to actually get the estimate. Oh, I'm sorry, I already did that. But anyways, the service benefits I just actually explained. And I just wanted to point out here, even though we ask for this, if a patient is uninsured, then what happens is when they hit copay, they actually have a pop-up that tells them what the next step is, so that you can see the uninsured patients. And this is actually showing us also all of the insurances that we have loaded today. And we have a list of about 25 more that we're going to be loading within the next 3 to 4 weeks. So then you finally can go to the next page because you press Get My Estimate, and you get a full estimate. Now, this is a very simple estimate, but you can see that under copay amount, we actually show the total, but we show what the hospital is and what the professional is. Same thing with coinsurance amount if there's a hospital and a professional, and if the patient gives a deductible, and what the responsibility of the patient is. And again, we're providing that this is the best estimate to remind the patient in case they forgot. They have the capability to print the estimate, and this is what they would see printed. And they also have the ability to reach out to our patient, to our pre-service center. What we are not showing here is the screen for our uninsured patients, but there actually is a screen that tells our uninsured patients what they can actually look at and talk to us. And if you go to page 24, you're going to see what they actually receive. And the reason we do this is because we do not want patients to become concerned if they're seeing an out-of-pocket expense that they cannot afford, and we encourage them to contact us. Now, we have a very rich financial assistance program for the uninsured, and so if they are uninsured and they're already on that program, they're aware of it, where you see Metro Health Financial Assistance Program. If they've never been through that program, then we give them another number so that we can work with them and make a determination if there's, again, HCE, Medicaid, other governmental programs, or one of our financial assistance programs that we can get them involved. And we don't charge anyone full charge. We have an algorithm based on where the uninsured and underinsured are seen, if it's trauma unit or burn unit, if it comes through our LifeFlight program, and or based on their actual level of income. And if a person truly is 100% self-pay and they don't qualify for what people would traditionally think is a financial assistance program, we still do provide a discount so that full charges are not billed to our patients. So basically, we service everybody, and the estimator is to engage the patient and be able to talk to them. One of the things I wanted to mention on the screen also is we had a lot of conversation, do we require patients, even with insurance, to give us our demographics, et cetera? We do not. That was a philosophical decision. That part of our philosophy was to give people autonomy, allow them to shop. Eventually, we may set up comparison shopping right on our website. So we did not want to require people filling out demographics or filling out an email address or a phone. We give them that as an option if they choose to do it once they print their estimate, but not as a requirement, because that would go against the philosophy of opening up this web portal to everyone, regardless as to whether they want to contact us or not. We can manage how many times it's opened, et cetera, but we do rely on the patient to let us know if they want to contact us.